One.
Good afternoon, ladies and gentlemen, and welcome to our 7th session of the transplant patient education program by Lifeboat Columbia University. We have a very distinguished panel of members today, and first of all, though, I would like to introduce to you my co-moderator, Dr. Karen Hechenberger, who is the CEO of Lifeboat. She happens to also be a recipient of a kidney and a pancreas, and is very expert, obviously, in the field. Our panel today consists of Dr. Ilona Wiener, who is a psychiatrist and assistant professor of psychiatry at Columbia University, Dr. Hilda Fernandez, who is assistant professor of medicine and of pediatrics, and she is very knowledgeable in all matters regarding both children and adults in terms of kidney transplants, and Ms. Catherine Sayosin, who is our supervisor for financial coordinators. I neglected to mention a very important person who really runs most of our program in donor kidneys, and that is Mr. Brian Runge, who is the supervisor of donor coordinators in our Columbia program. With that, and my thanks to Veloxis for partially supporting this program, I will turn it over to Dr. Hechenberger.
Thank you so much, Professor Hardy, and thank you to all the speakers here today and my co-moderators, Brian and Professor Hardy. So today's topic is quite exciting. We're going to talk about what happens post-transplant. We have taken you through this program through end-stage renal disease, preparation for dialysis, the process of dialysis, living and diseased donor, surgery, and how you recover post-surgery. And today we're going to talk about how you get back to so-called normal life post-transplant. So that's why we have such expertise here today from psychiatry and Dr. Wiener, and also the financial aspects of medicine in Catherine here. Hilda, Dr. Fernandez is of course representing the nephrology department, and there are a number of different concerns when it comes to the medical situation that aren't just concerning the actual transplant. We always have to remember, and I think this is very, very key, is that this is not just about a transplant of a kidney. This is a whole person. And this person continues to live post-transplant and needs to conduct his or her life. And we want to enable that, and we want to make sure that we're not just enabling survival, but we want to enable patients to thrive. So with that, again, I also want to thank Columbia. I want to thank all the people at Lifebulb who have put this together, as well as our sponsor, Veloxis Pharmaceuticals. So Dr. Hardy, why don't you launch with the first question?
Well, since I am a surgeon, let me start out by asking to our panel, particularly Dr. Fernandez, if a kidney fails and is rejected, can I get another kidney, and will that kidney work pretty well as well as the first one? This is most appropriate for you, since you supervise children, and they generally don't get away with one kidney transplant through their life.
That's right, Dr. Hardy. So children, this is a very common question. I think a lot of parents struggle with this, trying to decide also in regards to donors. If my child gets a kidney at the age of 5, that means that it's going to last maybe 15 years. They're going to be 20 years old. What are we going to do then? And yes, it is possible to get a second transplant. it's a matter of, working with your nephrologist to make sure that you have everything up to date so that you can move forward quickly so that you can get relisted. And we can talk a little bit more about that with Brian Rung. But it is more difficult in some ways because it's the second transplant. We have a patient that's now been sensitized and there are antibodies that are involved. So it might make it a little bit more tricky, but it is doable.
Great. Well, thank you. Thank you, Hilda. I want to move to an area that is a little bit outside of the pure surgery and medicine. And I guess I want to direct it to Dr. Wiener. Post-surgery, you're now living with an organ that has been given to you by either a deceased donor or someone close to you has given up an organ for you to survive. What's the common practice for you as a healthcare professional? Do all patients go through sessions or consultations with psychiatry, or is that something that you have to seek care for?
Okay, thank you. So actually at our program at Columbia, the recipients are, the only recipients who are seen by psychiatry are patients who have some psychiatric history or current psychiatric issues. I mean, it is a huge program, so we're at this point not equipped to see everyone, and there's really no need. A lot of people are doing okay and don't need psychiatric involvement. So that's how it sort of starts. And then if the person requires or would benefit from further psychiatric treatment or care or involvement, then we try to refer them out, which is a little problematic. It depends on what insurance patients have and where they're located. And there's just, in general, psychiatric follow-up is not an easy sort of endeavor. So, but we do our best. There are several clinics at Columbia University Medical Center itself, and then we try to facilitate, for them to be seen elsewhere or geographically sort of where it is convenient where they live.
Ilona,
yeah.
You mentioned that you don't see everybody, obviously you can't, but could you comment on anyone who asks to be seen, who expresses concern that are being frightened about the transplant to the point of not wanting it, or having an allergy to doctors and needles and or medications for that matter, or when coordinators or doctors evaluate them and find some problem that they just are not sure about, aren't these patients then referred to you and you do see them regardless of whether they have psychiatric problems before or on medications or so forth? But
Yes.
I think that you're really open to all these possibilities.
Oh, absolutely. Obviously, if there are issues identified and it happens, that people are hesitant to undergo transplant, that people have a sort of feel guilty taking a kidney from especially a living donor, someone who is related to them or even unrelated. People are concerned whether, as it was already brought up, whether they'll need another transplant, and that worries them that it'll be sort of, they'll be patients forever. They'll never sort of will be able to reach a point where they're like free of all this medical stuff. So there's a whole, there's just a whole spectrum of situations and questions on their part and fears. But the most, I think I have to say that the most common is when adult child wants to donate to a parent. And often these parents, the recipients, are really resistant and reluctant to take their child's kidney. So we often have these type of discussions. And what has to be emphasized that it's not only the recipient's decision, but it's also the donor's, the adult child's decision. If he or she feels that they want to do that, then they need to have that sort of freedom.
So in terms of donors, you'd see all the donors.
I see all the
in terms
donors.
of their motivation and
Right.
why they're giving and whether they're qualified to give and whether they'll be fine after they give.
In fact, isn't it a criteria for giving a kidney to pass evaluation by a psychiatrist?
Yes, yeah. So in most big
It's a requirement.
that is required that there is a psychiatrist who speaks to the donor and discusses, again, their history. Obviously, we have to be sort of vigilant in a way. Psychiatric illnesses can be tricky. So if there is that history, then we want to know, what is the likelihood that the person will be able to manage, will sort of be consistent with their decision, or might sort of change their mind pretty quickly. So there is a lot to discuss. Now there is many more of these non-directed donations. So that's sort of another whole area to explore what propels these people to do that, to, completely unknown individuals to help them.
Brian, would you like to comment or add something in terms of when do you refer a patient for psychiatric evaluation, even though it may not be a donor, or when do you feel uneasy about a patient? I guess that would be the appropriate word to use.
Well, like Dr. Wiener said, is if they have an ongoing psychiatric illness, but there's also different levels to those illnesses, maybe depression, it's very mild to very extreme. Some people might be doing okay, and maybe they don't really necessarily need to see Dr. Wiener or a psychiatrist. But usually here at Policy at Columbia or NYP Columbia is, if they have recipients wise, if they have a psychiatric illness, they're going to see the psychiatrist. They're going to see a social worker regardless, but then they will add on a psychiatrist. Do we as coordinators ever go ahead and just make the recommendation that it needs to see one? No, but we can. Have I ever? I think a couple of times in my career, I was worried about the patient, and they were kind of straightforward with how they were feeling.
We discussed this, but it's discussed at
it's discussed in our selection meeting.
Selection rounds.
Yeah.
Now,
yeah.
What about people who have a history of addiction in the past, or to alcohol or to drugs, and are now fine and are working and no longer are addicted? Are you concerned about those?
Yeah. I mean, you're talking about having to, if their addiction is to, say, pain medication, you're talking about doing surgery and giving them pain medications. So we are very concerned with that on the donor front, especially that I see it more often because I work with the donors, but it's there on the recipients. And we have to come up with a plan as a team. And usually this comes during selection, as we say, hey, look, this gentleman, had an addiction years ago, but has been clean forever, but we don't want them to, regress. So we'll come up with a plan. Maybe it's to see pain management, or even, I guess it's just pain management we would refer them to, but they also more than likely will see a psychiatrist.
Thank you. Thank you so much. I think we should just, because of our audience here is really indicating an interest in discussing more life post-transplant versus the specific psychiatric disorders that some very few patients are afflicted by. So thinking about post-transplant life and what are the different things that can be done versus cannot be done. Again, if we go to Dr. Fernandez and Brian here, are there any specific activities, and especially in COVID times, that you restrict patients in doing post their transplants? And if so, how do they overcome those different life aspects?
It's been challenging, definitely during COVID. Before COVID, we would, and I apologize if I'm not sure where everybody's been in this process, but let me describe what we usually tell our patients when they're going to get a transplant. Typically for the first 3 months, we try to restrict as much of their going out amongst particularly small children, any place where they're going to be in large crowds because of the effects of the immunosuppression up front. After that, before COVID, we were a little bit more, we could go out and do more things, go to a restaurant and eat and maybe travel by 6 months to some foreign locale that you wanted to do traveling. Everything changed after COVID. Now, we do recommend masking for the first 3 months, particularly for all our patients when they're going out, and we're trying to get everybody vaccinated that can be before they get their transplant. It's been difficult. What else would you add, Brian?
When I was taking care of the recipients, that's of course pre-COVID, that's very similar to what I would tell them. Is the first 3 months you have to be, first year, try and be as careful as you can, because the less rejection episodes you have, the longer that kidney could potentially last you, and getting sick can ultimately end up in a rejection episode. So we would tell them, for the first year, try and be very careful. First 3 months especially. But you also don't want to go as far as, because everybody's already have it preconceived in their head that, oh, they're immunocompromised. My life is changing drastically. I need to stay away from everybody and live in a bubble. And that's not what transplant's about either. We want you to get back to as best as a normal life as you really can. And most transplant patients can. It just is, what I try to drive home to my patients is just be aware of your surroundings. And COVID is bad. But what I kind of see what is good that came out of this is everybody suddenly learned about masks, not just us in the hospital.
That's
we all know about
exactly
it.
what my patient told me. He said, I was doing all this, Dr. Fernandez, before COVID hit, so I'm fine. Everybody else is kind of having a moment, but I've already been living like this. Things have, I think that hopefully going forward that will help.
Someone here asked whether you give Evishield to everyone who received a new transplant. I don't believe we do.
No, we do. So for the first, we offer it for anybody that's been newly transplanted.
What
So
about
newly
people who have been
transplanted, but not
transplanted for a long time?
Now the restrictions have come off. I think that it's now available to anybody that's ever been transplanted.
Okay, so that's one answer. And the other one was about activities. What,
Sorry.
What can they do?
In regards to going out for dinner and such, we still, I would.
No, what about going play basketball?
Oh, absolutely. I think I echo what Brian said. I think that you want to return back to being able to do the activities that you love.
Contact sports, no.
You pose any restrictions on them?
With if it's going to be something like contact, like basketball, I do recommend using a kidney guard. You don't want to get hurt in your abdomen. And otherwise, running and solitary sports like that, please. I think that's great as your body's able to tolerate it post-operatively.
In fact, isn't it a good idea to go back to some physical activity post-transplant?
Exactly.
Some of the side effects of the drugs that are given to transplant patients do cause perhaps weight gain or even insulin resistance. So having some sort of physical activity is a good thing.
Exactly. I think a lot of people gain a lot of weight after the first year if they weren't feeling well to begin with, and then now they suddenly have a lot more energy. They're able to eat more. That is a big problem that we struggle with. And as you just mentioned, one of the side effects of some of the calcineurin inhibitors is being more prone to diabetic issues.
Now we come to the question also of after you transplant, what happens? How do you pay for the drugs? How do you pay for the visits? How do you make sure you have the right insurance? And I think we have an expert on this. So Catherine, tell us.
Hello, everyone. So as you all know, transplant itself is a lifelong commitment. And with that, it could be very costly. So it is strongly suggested to go, investigate which transplant center would participate with your insurance, understand your out-of-pocket costs, your deductible, your co-pays, and most importantly, that's for your pre-transplant care, but for your post-transplant care, you should know your medication costs. If there's like an alternative to be able to get your medications besides, like, let's say for a retailer, you could get mail order where you could get 1 month free. So that's an additional savings. So just overall understand your insurance. If you are entitled to Medicare for kidney transplant with end-stage renal disease entitlement, you are entitled to that. So, just overall know your premium, your out-of-pocket costs, not just for hospital, medical doctor's visits, but also for your post-transplant care to be able to maintain that transplanted organ, be able to afford your medication costs, your copays.
So does Medicare cover it for the life of the kidney?
So right now, it is covered 36 months post. If you are only entitled to it based on end-stage renal disease / transplant. But there is now a law passed that you can have it longer than 36 months. So I believe starting next year, you would have that specific provision of having longer or lifelong of the organ.
So do you stay on Medicare for it, or do you just stay on the cost of medications by Medicare?
You have to have the Medicare. You have to have the Medicare from your transplant event. You have to have been covered at that transplant event in order for you to be covered. So there's specific provisions, but fortunately, a lot of our patients will be falling onto that category to be able to have a lifelong coverage for the immunosuppression under Part B.
Is this age dependent or not?
Nope. Medicare is a federal plan that is based on 3 entitlements specifically. It could be based on age, over 65. It could be based on permanent disability, but you have to have been deemed disabled through Social Security Administration. And lastly is the specific provision for end-stage renal disease, either on chronic dialysis or transplanted.
So Catherine, a question.
Sure.
These drugs that are covered lifelong, and again, I think it will take place starting in 2023, and we actually heard that today in our summit here as well. So that's a wonderful new law. My question is, does that law also cover the drugs that are consequences of immune suppressants, meaning some of the complications of immune suppressants may require antihypertensives, antidiabetics, or other drugs that are cause of the drugs that are covered? Are those self-pay, or are those also covered by this law?
So it should be covered by that law. So once you're entitled to Medicare for the hospital Part A and Part B, you should have eligibility to be able to qualify for the prescription drug plan. So therefore, all of your non-immunosuppression medications would be covered as well.
So Catherine, if you are 35 years old, you have a transplant, you continue to work and make a reasonable salary, can you hold on to the Medicare after the 3 years?
You can. You have to have had the Medicare coverage from your transplant event.
Right. Okay.
And been transplanted in a Medicare certified facility, which of course we are.
So a question, because this is coming from our audience, if you have, since this is a new law, that goes in, comes in place next year. If you have been covered for 36 months and then you go back on a private plan, can you now be covered by Medicare when you've had a gap of many years when this law comes in place next year?
So I think there is a specific cutoff. So if you've had your transplant for like, 20 years ago, and you will have to get the Medicare, either maybe disability or of age, but specific to that, I'm not sure if you would be eligible to sign up for Medicare specific to cover the medications.
But there is some retroactive coverage.
There is some retroactive coverage, but I don't think it goes as far back as, so many years. I'm not that, that's something that is relatively new, and I'm not that up to date or even studied what exactly is the provision. The homework of mine, Dr. Hardy.
For the next session in 23.
Great.
So now, what about the idea of, maybe I shouldn't ask this question, or perhaps I should, but how do you connect with other people who have had a transplant, who maybe can help you out with answering some questions? And perhaps I will turn to my co-moderator, who actually is probably more knowledgeable about that than any of us.
Well, I wouldn't say, but I can add my 2 cents. I mean, when I received my kidney transplant in 2009, there were very few ways to connect with other patients similar to myself. At that time, I was relatively young, not so much anymore, but at that time, and I wanted to connect with someone else.
It's all relative. Yeah.
That's true, Dr. Hardy. Anyway, but you're always going to be young. So and I wanted to connect with another person who was kind of at the stage of my career and my family planning and everything else that was going on. And it was very difficult. So from that time, I was very committed to try to create such a platform where I could connect with another person who I could share my experiences with, but I could also learn from. Because I'm of the opinion that you can always learn. I mean, that's part of life, right? Is learning. And you can learn from those who are older, you can learn from those who are younger. And we see that actually in our entrepreneurs here today as well, that you can learn from one another. So we created Transplant Life. It has been launched now a year ago, and that's a place for patients to connect with one another. It's an alternative to Facebook. We feel that it's more moderated, it's got additional services, and it's safer. But I know that there are other places as well where patients connect, including support groups at various different hospitals. With COVID, it's been more difficult to connect with patients live, and that's why the digital media or platforms have been very attractive for patients to connect through. But transplantlife.com is a place where you can connect with other transplant patients and share your experience in a similar.
Okay.
So that's one alternative.
Now, Hilda, can you comment perhaps on this issue that was just briefly brought up, is how, with this COVID business, have you had many more video visits? I know that I have in the past.
Well, yes, we have routine video visits now. I think it made it easier for people for a variety of reasons. It has extended our ability to reach people that may have difficulties coming into the New York area.
Someone asked that question. I forgot to turn it over to you. Now, in terms of this reaching out to talk to other people, Dr. Wiener, can you perhaps comment on that in terms of available services that we may have at Columbia or that are available elsewhere, where you get a worried patient coming to you who just wants to talk to someone who has had a transplant or who donated a kidney, and they want to make contact with someone who has had the experience, or several people who have had the experience?
Well, so in terms of just getting in touch with people who've had similar experiences or who've been either donors or recipients, I think the easiest way actually is through our own program and our coordinators who facilitate that. I mean, I often come across, like, for example, a potential donor or a potential recipient for that matter, who would like to speak to someone who went through this experience. And that's usually facilitated if possible. Now, in terms of wanting to outside of the people who went through the same experience, but if one wants to just have an outlet and be able to talk about themselves and sort of bring up whatever fears and concerns they have, then obviously the best way is to try to direct that person for psychotherapy. As I said at the beginning, there are some clinics that are affiliated with Columbia, plus there is a faculty practice at Columbia, so people can be referred there or outside of our institution, where in their sort of geographically where they're located. Although now, because of COVID, we've been really seeing a lot of the having televisits and so that's sort of easier in that way, in that sense, but it's only then restricted now to New York State because we cannot see, psychiatrists cannot see patients if they're not licensed in other states. So even televisit would be easy to participate in, but because of the licensure, it's not possible for other states.
And Brian, have you encountered this issue of patients asking you to talk to someone else about their issue? Yeah, they do that all the time, don't they?
We have on the donor side, I keep a list of post donors that say, hey, I'd like to, if anybody wants to talk to me, I'll be happy to talk to them. It's not utilized as much as I think I would even like to see, but I have that list of donors that are willing to talk to other people. Every so often I'll get a donor that wants to talk to somebody their age that went through this. On the recipient side, I've had that asked of me a couple times, but not as much as the donor. And I just tried to call around a couple of my recipients that were the same sex, same age range as this other recipient, said, hey, would you mind, talking to this gentleman on the transplant list? He's curious to see what it's like post-transplant. And as for the virtual visits and things, they've opened up a world of being able to get patients in the door sooner, but the licensure is an issue. I understand why it's done, because you can't really practice across state lines. But when COVID first hit, the licensure was released, and all the nephrologists could see everybody, so we could get more people in the door. And
now actually the surgeons and the nephrologists can get their license renewed very quickly in both New Jersey and Connecticut. It is facilitated, I think, for the next 6 months. And that's another story. Before we run short of time, let me ask the important question that many young women who may want to get pregnant invariably ask whenever they're ready to get a kidney or have a kidney for that matter. And that's obviously a very important question for them. And I'll turn this over to Hilda first.
So yes, it is possible to have a child, and there's many ways to have a child. What I counsel my patients on is that we would prefer that they wait for a year after their transplant, because that is the highest risk for rejection. We want to make sure that you're also not going to be at risk for rejection after that year. We want to make sure that you haven't had any recent rejection episodes, that your kidney function has been very stable, that you don't have any signs of serious dysfunction, because one of the issues during your pregnancy will be trying to monitor your immunosuppression levels, changing your medications around.
What do you change? Tell us what you change.
If you're on a particular medication called mycophenolate, we do have to switch that to azathioprine. due to the toxicity, the terotoxicity to the child from the MMF.
What about Prograf or
So
cyclosporin?
that's the one that is a little tricky, because during the first trimester or so during your pregnancy, your levels will pretty well stay the same. But during the next couple of trimesters, unfortunately, the levels can be very variable due to the expanding volume of water in your body, let's say. So we end up having to keep a very close eye. So there's a chance of rejection there as well. But I've had multiple happy mothers. Also, the other thing to consider is there's other ways to have children there. We also, we partner with our MMF OBGYNs here, and also talk about other ways that maybe surrogacy, things like that.
And in terms of the size of the baby and normalcy of the baby when they're delivered?
Tacrolimus CNIs may cause some smaller birth weights, but to my knowledge, there is no terotoxicity to the baby.
And the ones that are terotoxic are the mycophenolate and Cellcept and all that, and those are discontinued.
Those have to be stopped before
And
you
substituted for.
Correct.
I just
So-
want to emphasize it.
So we just got a question that is very dear to my heart, and I think this is very important, the pregnancy. And it's nice to hear from Dr. Fernandez that it's possible, but it's a very complicated process, and we need women to be truly guided through this to be safe both for the woman and the child. But it's nice to see that you're so supportive. There's a question from the audience which says, these drugs that you're talking about, I've been on them for close to 20 years and they're still the same. What's going on in the transplant world when it comes to innovation on new therapeutics? Why am I still on drugs that are now generic? Why is there no innovation? Dr. Hardy.
Dr. Fernandez, you want to take that on?
I think there
Or
is.
should I take that on?
I think you can take it on quite well. But,
Because I'm
I would
20
say
years old, right? So,
there have been some innovations. I apologize, I don't know what medications you're on.
So the person is on, let me see. Well, it doesn't matter because all the drugs except for belatacept are old. So we've got tacrolimus, we got azathioprine, we got mycophenolate, we got a long-acting version of tacrolimus, which is a great advance, but it's still only a long-acting version of tacrolimus. So what's going on?
So there are many trials of various monoclonal antibodies which have not really succeeded either in preventing disease or in substituting for any of the drugs that we're using. The only one that has had some advantages, I think, is belatacept, which was licensed about 5 years ago, I think. Prograf actually was not licensed for kidneys until around 2012 or so. So it was used since 1998, but it was off-label at the time. So that's why it was never generic until afterwards. And the effort is being made. The problem for the pharmaceutical companies is they still feel that the market is not large enough to invest enough to develop.
Dr. Hardy, I must beg to differ because there are a number of orphan drug companies out there that are doing very well in even smaller areas than transplant.
Well, that's true, but the investment in order to do this, in particular in production of monoclonal antibodies and of any sort, requires big companies, not little companies, unless they're one drug companies. So the interest, I think, is not as great because the companies feel that the profit margin is just not enough for them, I think. Originally, with the development of cyclosporin, which was the original Prograf type drug, actually Sandoz and then Novartis became one of the largest companies in the world just with that. But afterwards, it's not been as successful for the companies, particularly once their drugs become generic. So I think that the problem is that there is no innovation in terms of both the of production, nor in fact in research. The greatest focus now is on so-called induction of tolerance, which involves various specialized drugs at the initial phase of transplant. But unfortunately, that has not succeeded as effectively as one would hope.
Well, I think
however, if you want to hear more about this, come to one of our last sessions. We are going to have, the next two sessions are going to be about the pancreas transplant, but afterwards we will have two sessions on innovations in transplantation with guests who will comment exactly on the question that you raised, which remains a problem for all of us.
I think that's a good teaser for our next few sessions, where we will talk about xeno, which means a transplantation from a non-human organ. And we've seen some great examples over the past 6 months with pigs from various different institutions, including a New York one. And we will also talk about cell therapy. And those are some interesting seminars to look forward to.
And organ repair.
In
the meantime, are there any other questions that are hanging on?
No, I think we have answered our questions. Oh, we have another one. I wish there was a drug that would replace prednisone as one of the immune suppressant medications.
I would be delighted to comment on that. So I was very eager to get rid of prednisone. And actually, as the director of the unit in the past, I'm emeritus in that sense, we discontinued using prednisone in almost all renal transplant recipients since the year 2000. So for the last 22, or actually more, 24 years almost, we have not used prednisone except for the first 5 days. Now, this has not been adopted, obviously, by all the units in the United States, but I think anywhere between 30 and 40% of units act the same way, then maybe even more. So it is quite possible not to use prednisone, and that actually is still effective, and the results are no different as long as the patient remains on 2 drugs. So they have to be on some combination of 2 drugs other than prednisone. Some people claim that the combinations are different by various units, but not very different, as someone mentioned before, because we don't have that many choices, but we do have some. So we have the calcineurin inhibitors, which is cyclosporin and Prograf, or Envarsus, which is the 1-day drug. Then we have also something called rapamycin, which has not been very popular for various reasons, but can also be effective as one of the drugs. And then we have the so-called generalized inhibitory drugs, and that includes the original one, which is azathioprine or Imuran, and the other type is the mycophenolate, which includes Cellcept and which one is it? Help me. It's mycophenolate mofetil. Anyway, there are various now types of Cellcept drugs, but those combinations can avoid prednisone in some cases, and most of our patients, almost all our patients, except those who have been on
Myfortic.
What?
Myfortic,
Myfortic, that's it. Sorry, I just blocked.
Yeah.
The,
Yeah.
but they, the patients that need continued prednisone, we feel, are those that have been for a long time on prednisone for their native kidney diseases, such as lupus or various forms of glomerulonephritis. Those patients need a low dose of prednisone in order to keep recurrent disease from coming back.
Great. Well, thank you. And thank you, Dr. Fernandez, for answering the question from our audience regarding homeschooling. And if you have children of very young age and you have just gone through a transplant, can you afford to keep afford risk-wise to keep your children in school, or should you homeschool them? And Dr. Fernandez's response was that you recommend homeschooling for the first 2 months of those children to avoid the risk of infection. So thank you for responding to the audience in the written way. I think we've reached a point where we've finished this seminar, and this was a great way of speaking about post-transplant and allowing for more information out to our patient group about living life with a transplant. There are many more questions and many more topics we can cover, both from a financial perspective as well as how to thrive, and of course the details on how to allow for family planning. But all that can be, I think, addressed in questions to us. We are open to questions post the seminar, and we plan to continue with additional educational webinars going forward. So I thank the panel members and our moderators, and of course, I know Dr. Hardy wants to say a few words.
Well, thank you all for being very active and very informative participants on a topic that's really difficult and more or less endless, really. There are many, many more questions. They come up as we continue living and working. I do want to ask to convey apologies of one of our panelists, and Dr. Ratner, who is the director of transplantation at Columbia. He had a personal issue that he had to solve unexpectedly today, and he will participate in other sessions, but couldn't do it today. So again, many thanks, and I hope that you all have learned what you wanted to learn from this session. And as Dr. Hechenberger commented, you're welcome to ask further questions, and they will be referred to us for written answers via transplantlife.com.
Thank you.
By the way, these sessions are archived, and you can listen to them again and again. And that may be of some use, but it certainly may be of use to your friends. So goodbye and have a great evening. Thank you.
Thank you.
Thank you.
Thanks.
Thanks.